Infected versus affected caries. The treatment of deep carious lesions approaching a healthy pulp presents a significant challenge to the practitioner. The traditional management of carious lesions of any kind dictates the removal of all infected and affected dentine to prevent further cariogenic activity and to provide a well-mineralized base of dentine for the restoration. When the procedure risks exposing or even breaching the pulp, the course of the treatment becomes less predictable and may require such measures as indirect pulp capping, pulpotomy, or in most extreme cases, pulpectomy. The deep caries can be removed by stepwise excavation or direct complete excavation. The following studies have concluded that stepwise excavation is effective for pulp preservation in extremely deep caries where there are no clinical symptoms of irreversible pulpitis. Like how remineralization of enamel carious lesions are possible with the help of agents such as fluorides. Similarly, remineralization of dentine carious lesions is also possible with calcium hydroxide and other materials such as antimicrobials and polycarboxylate cements combined with tannin fluoride preparation. In indirect pulp capping, all carious dentin typically is removed from the walls and the dentino-enamel junction of the cavity preparation. A layer of deep carious lesion, which is usually discolored but firm, may be left on the floor of the preparation if its removal may cause a pulpal exposure. Direct pulp capping is used when the pulp is visibly exposed due to caries, trauma, or iatrogenic insult such as an accidental exposure during tooth preparation or caries removal. Typically, liner such as calcium hydroxide is placed and overlaid by a provisional restoration such as zinc oxide eugenol or glass ionomer. The procedure typically involves arresting any pulpal hemorrhage, followed by covering and sealing the exposed pulpal tissue. The ultimate objectives of any pulp capping procedure should be to manage the bacteria, arrest any residual caries progression, stimulate the pulpal cells to form new dentine, and to provide a biocompatible and durable seal that protects the pulpal complex from the bacteria and noxious agents.
Looks are deceptive is a well-known saying. Hidden caries or occult caries is a term used to describe carious lesions that are not visualized clinically but can be detected radiographically. Prevalence of such caries was found to be from 2.2% to 50% in permanent molars. It also has been reported in premolars and primary molars. These were thought to be initiated in either deep fissure walls or base of the deep fissures. Other theories suggest that the hidden caries can be a consequence of fluoride syndrome. In this case study by Alcodier et al., in 17-year-old male who presented with just a dark shadow underneath the intact enamel surface with lower left mandibular premolar, which on radiographic evaluation followed by excavation of caries led to the extension of the cavity halfway through the dentine. Another example of deceptive looks is the fast break phenomenon. It is a term that relates to the splitting off of a single canal into two separate canals. In case of premolars, the break is often buccolingual. Therefore, on straight-on radiograph, a large thick coronal canal that suddenly narrows and becomes difficult to discern is seen. Another example is for localization of radiolucencies and radiopacities associated with the root apices. In the first picture, it appears that radioopacity is associated with the distal root, but when the buccal object rule was applied with the second radiograph taken with an mesial angulation, it became clear that the radio opacity was not in contact with the root but was more buccal. This buccal object rule was described by Clark in 1910 and refined by Richard in 1953 and 1980. According to this rule, when a radiograph is performed at a certain angle, the object close to the radiographic source is displaced in the same direction as the X-ray beam. This rule can also be used for visualization of the canals which may appear superimposed. Thus, radiographs prove to be an important diagnostic tool. With further advancement like the use of cone beam computer tomography, 3D visualization of the root anatomy is possible.
It is always best to start planning with the end in mind. The effectiveness of the planning will be finding the right balance between not enough and too much. For more than 30 years, the specialty of endodontics has recognized the importance of respecting the root canal anatomy, and that is where minimal invasive endodontics comes into play. Now, this minimal invasive endodontics involves judicial care of three areas, that is, access cavity, apical preparation, and the preservation of pericervical dentine of tooth. Now, the traditional endodontic access emphasizes on straight line access into the root canal, as seen over here. Now, major concern related to this type of preparation is the amount of tooth structure that is removed, which may reduce the tooth resistance to fracture. Now, in order to overcome this limitation, David Clark and John Kademi came up with a new design known as conservative endodontic access cavity, also known as ninja access or truss access, in order to minimize the tooth structure removal. Now, when it comes to minimal invasive endodontics, the biological and the mechanical objective of access preparation, as well as the concept of minimal invasive endodontics, should coexist, such as the access preparation should not be too small or too big, as a too small preparation is going to obstruct the view of the operator, and when it comes to a bigger preparation, it results in unnecessary removal of the vital tooth structure. Now, in this era of enhanced lighting and magnification, as well as with the introduction of new flexible rotary instruments, it has helped us to achieve the objective of access preparation with minimal invasive endodontic concept. Now, another important factor to consider when it comes to minimal invasive endodontic preparation is the preservation of the pericervical dentine, which is basically the area of dentine at the plane of alveolar bone, 4 millimeter above and below it. Now, it has been said that no man-made technique or material can ever compensate for the tooth structure lost in the key areas of pericervical dentine, as it plays a crucial role in transferring the occlusal forces along the root. Now, when it comes to making a decision whether pre-endodontic buildup should be done or not, sometimes it becomes imperative in certain situations to restore the tooth prior to the start of endodontic procedure, especially in cases where both the marginal ridges are completely denuded because of caries. Also, in the present context of minimal invasive dentistry, whenever possible, one should keep in mind to give an intracoronal retention in the form of inlays with cusp coverage or onlays or even endodontic crowns. They are preferred compared to the use of two materials in the form of core and crown, as these restoration has shown to preserve the dentine girth as well as provide the ferrule effect in a more effective way. So the journey from GV Black's extension for prevention to minimal intervention should be the sought option for the clinicians today.
Coming to working length determination, we have to consider some classic papers such as that of Yuri Cutler in 1955. Yuri Cutler very eloquently described the difference between the apical constriction and the apical foramen. The apical foramen is what we commonly experience when we look at a radiograph and we try to determine whether or not the file is at the right length. However, through his research, we found that the apical constriction, which is also the cemento-dentinal junction, is the area in which we want to instrument to and to obturate to for optimal results. However, we have to remember the only way we can determine the cemento-dentinal junction's position is histologically. When we look at the working length, Looking at radiographs, we have to remember that it is a two-dimensional image through which we are trying to determine a three-dimensional point of reference. Even if we have a good reference point, we have to remember that an actual working length may appear on a two-dimensional radiograph to be accurate. But if we were to examine that root end, you may see the end of the file sticking through the root. The reason for this is the portal of exit does not always come out at the exact end point of the root. That is why it is important for us to implement the use of apex locators. Research has shown that using an apex locator, working length determination accuracy was as high as 96.7%. Other advantages of apex locators are to detect and locate root perforation, diagnosis of external and internal resorption, diagnosis of horizontal or vertical root fracture, and the number of radiographs taken can be reduced. Hence, we can conclude that the radiographic apex does not coincide with the anatomic apex of the tooth, and apex locators can be used as adjuncts for working length determination more accurately along with radiographic methods.
Single and multiple visit root canal treatment has been the subject of long-standing debate in the endodontic community, not only on the biological and efficiency point of view, but also on the operator and patient's comfort, satisfaction, and preferences. In this modern era, fulfilling the patient's need in minimum visits and performing a painless procedure is of utmost importance for the endodontic management. That is why single visit endodontics is preferred by many patients as well as clinicians. But there are few scenarios where single visit endodontics will do more harm than good, like persistence of exudation due to over-instrumentation, in case of necrotic pulps, in cases of acute exacerbations, that is flare-ups, and in cases where there are weeping canals. So in these scenarios, calcium hydroxide plays a very vital role. In a study by Law and Messer et al., it was seen that in addition to mechanical debridement and antibacterial irrigation, dressing the canal for 1 week with calcium hydroxide has been shown to increase the percentage of teeth with negative bacterial count to around 70%. So the biological benefit of multiple visit treatment is that the bacterial load can be further reduced by an antibacterial dressing in between the appointments. Thus, including calcium hydroxide dressing between appointment provides a higher healing rate because bacteria are further reduced. So in case of persistently wet or weeping canals, calcium hydroxide is the medicament of choice, and in such cases, multiple visit endodontics is preferred. Other indications of calcium hydroxide include it is being used as root canal sealers, it is used in apexification, it is used in root resorption cases, in cases of avulsion, and in root fracture cases.
Obturation is the critical step of the root canal treatment. With the enlarged arena of newer equipments and better techniques, it has become a predictable paramount to success. Cold lateral compaction technique, widely used in earlier era, didn't do justice to wide canals and created voids. Now the thermoplasticized technique paves way for better outcome in regard to wide canals, failed cases, and cases where healing of the periradicular tissues failed up after successive attempts. With the sea of sealers available, how to choose what with which technique is a question. According to the present literature, it is advocated to not use H+ sealer with warm vertical compaction technique. This is because the heat used in this technique interferes with the polymerization of the sealer and causes voids. Hence, the recommended sealers for this technique are Apexit Plus and MTA Filapex. Now, historically, a single cone technique was used with zinc oxide sealer or resin cement in a canal of variable taper preparation that resulted in lot of space around the cone due to the shrinkage and the resorption of sealer over time. As a result of these two specific limitations of zinc oxide eugenol cements, the term single cone technique was associated with low quality obturation. This led to the search of newer techniques to compensate for these shortcomings. 10 years ago, when bioceramic materials came into the market, it gave a clear view on why single cone technique did not work, and it was mainly due to the sealers. The technique for obturation with bioceramic sealers is known as hydraulic condensation. Now, in hydraulic condensation, what exactly happens is the bioceramic sealer doesn't act as a sealer but acts as a root canal filler, and the guttapercha is merely a carrier. A lot of scientific evidence has been advocated that the fact that voids which were a pitfall could be efficiently sealed with this new age bioceramic material. Therefore, bioceramics are surely the future of endodontics and should be explored well.
Speaking about large periapical lesions. So earlier, it was always thought that large periapical lesions, more than 5 millimeters in diameter, have a poor healing outcome and would often require a surgical treatment approach or extraction. However, with a great deal of research, it has been seen that periapical lesions, even up to 20 millimeters in diameter, can be successfully managed with a non-surgical endodontic treatment approach and has a success rate of up to 93% at a 5-year follow-up period. And therefore, a non-surgical procedure should be considered over a surgical procedure. Now, persistent periapical lesions. Should the tooth be extracted or attempt a retreatment? A web-based survey by Axoy reported that most of the general practitioners and undergraduates advised extraction in cases of persistent periapical lesions more than 5 millimeters in diameter. However, majority of the endodontists preferred a retreatment even in more than 5 mm lesions. Now, a retreatment should be attempted at least twice following the standard root canal treatment protocol, after which, in cases of failure of the above, a surgical approach can be employed, and only if both these techniques fail, then should one go for an extraction in cases of a persistent periapical lesion. Now, talking about teeth with open apices. So, regeneration of the human dental pulp, is it a myth or a reality? Earlier, calcium hydroxide epixification and empty apical plug were the techniques employed for management of necrotic permanent teeth with open apices. However, due to its various disadvantages, such as weakening of the root dentine due to the calcium hydroxide and absence of root maturation, regenerative endodontics that includes pulpal revascularization and tissue engineering was developed. And yes, regeneration of the pulp is not a myth, and successful outcomes have been seen with various studies. Nicoloso, in his systematic review, also stated that pulpal revascularization has advantages such as root maturation, that is, increase in root length, and also closure of the apical foramen over epixification, and hence it should be considered as a treatment of choice in management of young necrotic immature permanent teeth.
Now, the topic of post and core is pertinent to both endodontics and general dentistry. Now, each clinician has a unique way in which he or she performs successful post and core in the field of dentistry, and the field is highly complex. Now, whenever the tooth, when more than half of the tooth structure is missing, the placement of the post is considered, and the length of the post should be at least 2/3 of the length of the root. Now, during the removal of the guttapercha, at least 4 mm of the guttapercha should be retained in order to maintain the apical seal. Now, clinicians are often curious about which post system is best, when in fact, no post is the best post. Now, the more conservative a clinician's access, the greater the likelihood of obtaining the longevity from the root canal or restoration in general. And the preparation of the post paste should be done immediately after the root canal treatment in order to prevent the leakage. Also, the clinician is more aware of the anatomy of the root canal. Now, there are two types of the post, that is Custom post, which is usually used for the extremely fair canal or when more than 3/3 of the coronal tooth structure is lost, whereas the prefabricated post is used when a smaller canal or when at least half or 2/3 of the tooth structure is lost. Now, the diameter of the post should be less than 1/3 of the diameter of the root, and at least 1.5 mm of the dentine should be present. Now, the clinician should aim to place the post in the canal with the straightest path. Now, it is usually the palatal canal in the maxillary molars and the premolars, and there are times when another canal, such as the buccal canal, can offer a straighter option, but generally the palatal canal is the best option, and for mandibular molars, it is the distal canal. So when restoring a tooth, it is optimal to have 3 mm of the wall on one side and 2 mm on the other, which indicates at least a 2 mm ferrule. And with this condition, the clinician is going to have a higher chance of success in order to reduce the incidence of the vertical fracture by 1/3. Thank you.
ENDO-CROWNs. Traditionally, the functional and aesthetic recovery of endodontically treated teeth with extensive coronal loss has been achieved by fabricating total crowns supported on cast metal cores. But with the development of intraradicular posts made of glass fiber and of the technique of bonding to dentine, resulting from the development of resin materials, the restoration of endodontically treated teeth became more simpler, more economical, and biocompatible. With the advent of adhesive dentistry and the new resources that may be used to perform restoration of total crowns in endodontically treated teeth, led to the use of endo-crowns. So what is endo-crown? It is an only restoration on endodontically treated teeth, which is more conservative than traditional post and core system and uses the adhesive resin with monoblock technique. So the concept behind endo-crown is to engage the large pulpal chamber of root of treated molar teeth with ceramic edged restoration, which provides cuspal coverage. Talking about its indications, it is indicated in successfully root canal treated molar teeth. Secondly, where there is excessive loss of coronal dental tissue and limited interocclusal space. And finally, it is indicated where in molar teeth, we see short and calcified canals. To name a few contraindications, it is contraindicated in parafunctional habits like bruxism. Then in cases where we can't obtain adequate isolation from saliva, then in certain cases where the depth of pulp chamber is less than 3 millimeters and cervical margin is less than 2 millimeters wide. And finally, if adhesion can't be assured. Its advantages being less complex and more practical and finally easier to perform. It allows minimal tooth wear, thereby strengthening the tooth surface. And the preparation design is very conservative and the biological width is minimal. It is more advantageous to us endodontists because it allows re-entry to canals if required without the post removal, which is a very big boon for us. And finally, it reduces the patient cost and chair side time. To name a few disadvantages, it poses a risk of debonding and root fracture in endo-crown. And limitation may be restricted to the ceramic material, which must be acid etchable ceramics. And it cannot be used in central teeth and premolar teeth. So finally, why do we choose an endo-crown? Because of two basic factors, that is longevity and effectiveness of it, and the choice of materials which is used to fabricate it. So there are several studies which concluded that endo-crowns were more resistant to compressive forces than conventional crowns. And more recently, The finite element analysis highlighted the role of endocrowns in stress distribution. So in choice of materials, we have glass ceramic, which is very advantageous to us because of its biocompatible nature and biomimic feature, and its wear coefficient, which is as close as to the natural tooth. In addition, the single interface of a one-piece restoration enhances the cohesion. Thank you.